Okay, welcome back. We're moving into segment 3 or part 3, which is signing in and into test mode as well as triaging a patient. So I will share screen now. So you're going to click on your HCIS or your MediTech workstation. And at this point, you'll press enter. Number 2 for test. Your user ID is MURSING, nursing 4. Enter 5 capital A's, 1, 2, 3, 4, 5, and the number 1, 2, 3. 1, 2, 3. Enter. You're going to choose number 1. And your facility is capital BVH. Enter. Once you get to this page, we're going to choose tracker, private tracker. So I'll click on private tracker, and we have a patient there already. I will actually review going through making a new patient for you. A lot of the screens in the triage assessment are similar and have some similarities to what you'll be doing when you are assessing and reassessing your patient. So this just an FYI is what we call our triage nurse tracker. Looking at this, I can see we have a patient who's a level 4, age 66, assigned to the green zone. Name test Sunny, they're highlighted royal blue. That highlighted name means that there's somebody else in the department with a similar name. So I will tell you right now, there's probably another person in there with the name test in it. And in turn, this is just to forewarn you, a cautionary sign, make sure you're charting on the right patient, because our refresh happens frequently, and in turn, when you think you're highlighted on a patient and you're documenting on them, it might be somebody with a similar name. Sex is female. Chief complaint sits in this category. So cough, congestion. Their status is they've been triaged. This is the comment. CCI is for critical results or critical indicators. And in our emerge, this specifically is set aside for any infection control indicators. So a previous VRE or MRSA, and you would see that highlighted right in this space. TID is time in department. Okay, we're going to create a new patient. So we're going to click on reception. We're going to put in a new name. So test, I'm using test again. And what am I going to use? Happy. Arrival date and time come up when you press enter. You choose the sex. I'm going to choose a female. Birth date, again, putting in its month date. Make this patient a little bit more elderly. They're 91. The complaint. So patient stated complaint for today will be cough. When we enter, it takes us to chief complaint. If I put in the first 3 letters and do an F9 lookup, it should bring me to the EDIS complaint list. Sorry, excuse me. This list is compiled through OHA. It's a standard list that we have across Ontario for chief complaints. They've narrowed it to about 167, to be honest. And this allows us to hone in, focus, and get the most appropriate chief complaint for this patient presentation. I chose cough and chest congestion. At this time, as a triage nurse, you're going to go to the infection control screen, or what we call our FRI screening tool. So it's up here under Update Assessment. I'll click on that. This again asks us, are we taking are we directly taking the patient into the treatment area? In other words, are they potentially a CTAS1, and are we going to document on paper? For today, it's no. I'm going to enter. Is this a new worse cough, shortness of breath? For my patient today, it's yes. Fever, shakes, or chills in the last 24 hours, yes. And yes, I'll initiate droplet and contact precautions. Unexplained diarrhea, no. And patient unable to answer, no. Have you traveled to any other country in the last 21 days? The answer is no for my patient. Unable to answer. I'm going to skip past that. They've got a potential COVID score here. And we're going to enter. This is in test mode, by the way. We're going to contact with a sick person who traveled in the last 21 days. And that answer is no. Are they unable to answer? And then hospital admits within 12 months. And our answer is no for this patient as well. So knowing that all of these have been in existence for quite a while, the FRI screening tool, and it's our means of helping with infection control. So admits within the last 12 months, you put in or state the hospital that they were in. Enter. Isolation precautions required. A lookup. I am putting them on contact droplet. And were there CCI indicators on triage for us today? No. This would have come forth to us if we put in their registration / health card number. When we were entering those quick demographics at the beginning, the system would have indicated yes for us, and we would have seen them. Is the patient presenting as a risk of harm to others? I'm saying no for today. And is patient presenting as risk of harm to self? And I'm going to say no for that today too. If we said yes, it would prompt us to go to do a risk assessment tool for these patients. One is for suicide risk, the other is a DASA tool. So today, we're not going to be reviewing that. Implied consent denied is just as it states. Implied consent, it's a double negative. Implied consent, when it says denied, in other words, we are a standard healthcare facility, corporation of a hospital, and yet knowing that the data has a healthcare flow to it when we do submit patients' information, yes, it will go and be retrieved for perhaps statistic purposes, etc., within the healthcare sector of Ontario. If a patient presents and says they absolutely do not want anything revealed, they want to remain nameless, they have that option. We make this an automatic no, unless the patient has brought that forward. If you need any more explanation about that, please let me know, but that's the basics. I'm going to just go quickly past to there. We're back to our triage level. We don't assign it yet. We'll move to ED location, and the F9 is number 2. We're going to enter, and the file, now you can do. So we have Happy Test, who's 91, whose already name and chief complaint are flagged red because we made them droplet contact. So when a chief complaint comes up red on our tracker, that's indicative of infection control precautions being applied. Great indicators, great visual triggers for our staff. Okay, patient is highlighted. We're going to come over now to go to triage doc. And in this screen, we're going to go down to triage assessment. We're going to right click on document. We're going to bypass this page because we've already done this, so we can page down. This will take us to the first part of triage. If you enter, you're automatically going to have your chief complaint come up. We're going to bypass by entering, just pressing enter past the EMS. We're going to state F9 that this patient is ambulatory. This is your chance to do your subjective. Not sure why it went there so quickly. I'm just going to move out. Okay, we're going to F9 here. We'll choose ambulatory, and then we're going to write a triage assessment. So patient complaining of cough for 3 days, non-productive, pale in color. I should put skin. And basically you would write your objective data here, your and subjective. We're going to move down to temperature. So we'll put in our temperature reading for this patient. It's 38. The temp source, oral. So a quick lesson about temperatures. Adults preferably is oral. Children 4, 5, and up are oral preferred. Axillas already is a secondary choice if they're unable to handle the oral probe. Tympanic, to me, is considered last resort. Tympanic is more of a screening tool, screening method of taking a temperature. Definitive definitely would be oral. And then, of course, rectal. So rectal in emerge is not uncommon. We use this for our decreased LOAs, decreased level of awareness, or LOC, level of consciousness. We use this for our seizing or postictal patients. Children often, 3 months and greater, we can do rectals on, especially if you have the training. We wouldn't want you to do this on a child whom you weren't comfortable with, or nor had you had the experience. Under 10 days corporately, a child, an infant 10 days or younger never gets a rectal. We do axilla. And between 10 days and 3 months, right in there, you can continue to do axilla if you're comfortable. Like on our pediatric floor, they will do rectals. And some of our triage trained nurses have that skill as well. So remembering oral, and then if you need screening, tympanic is fine because it alters with temperature of ear and the environment that they've just come from. So that's our goal. Pulse, for today, her pulse is 88. And we do need to know, is this regular or irregular? This can help with things around new atrial fibrillation or an old atrial fibrillation that's not being treated. And very good for you to ask the patient this question the minute they come through. Respirations for today is 20, blood pressure 148/88. Location, we like to state where, so I'm going to say left arm and what position the patient was in and sitting. O2 sat 90, so this lady's 91 with a cough. We're going to probably suspect COVID for her. Her SAT is 90. Lots of details around suspected COVID triaging, which I won't get into right now, but details have changed almost weekly, or if not quicker, with some of that data. So triage is evolving with the pandemic. Cup refill, we're going to look at quickly. I'm knowing that, and our standard is less than 2 to be considered normal. With cap refill, you are doing the fingernail bed test. We can also do against the bony prominence. So you could do forehead, chin, and sternum. Knowing for children, we prefer sternum or little ones, infants as well. Of course, fingers are immediate go-to, but even for our elderly, forehead and chin are acceptable as well. Weight, we would always get a weight on a child. So child The terminology for a child at QHC is under 18. And of course, for pediatrics, majority of their medications are weight-based, so we do need the weight. Pain, a big topic. So pain for Our Lady today, I'll say yes. We'll get a pain scale of perhaps 4 for her. 0 to 10 is what we would say to the patient. So can you give me a number between 0 and 10 about and to rate your pain at that? This is often challenging for patients. We have developed some tools, new tools for our merges. I'll show you what actually we've developed new Lego, hopefully you can see that, new Lego assessment faces, and that was developed through a BPSO group here. Very valid tool. Hopefully you'll see it when you're on your floors or in the emerge if you have to come. And it's for not only children, it's for our elderly, it's for those who are unable to verbalize if they're awake or alert enough. So 0 to 10 is your questioning, always stating 10 being the most excruciating pain that you have ever felt. We cannot refer, it's very subjective as you know, and we cannot give them ideas per se, like being hit by a Mack truck or having a child or renal colic, because these are definitely not every patient has ever experienced such a thing. So we say for them to relate to their own pain experience and the most pain you've ever occurred or ever experienced, I'm sorry. Chronic versus acute. This is language within emerge nurses and within triage. Chronic typically has timeline of 3 months and greater. Acute, about a month. So some people think acute is just a week or even 4 or 5 days. You could say you've had a migraine that's been off and on for the last month and you're under investigation. We would still consider that acute. Again, between that 1 month and 3 month time period, there's a couple months in there. So hence, it's not 100% black and white, but knowing chronic pain is the 3 month, typically greater than 3 months. Today, I'm going to put her acute pain level at 4. With cough, develops chest pain. Remembering the pain scale is done at that moment in time when they're sitting there. The GCS, Glasgow Coma Scale, is here. If you feel you need to, you would utilize that. So definitely a head injury or trauma, altered LOC, pupils as well measured for any of those conditions, you know, visual disturbances, etc. So LOC here is listed as, I'll look it up for you, alert, confused, drowsy, response to pain or unresponsive. Our patient is alert. Enter. This is our allergy management pain screen, I'm sorry, allergy management screen. And in this screen, knowing that you are the first nurse, as a triage nurse, you're the first nurse seeing the patient, and this is the time to get their allergies immediately. It is part of our standard as nurses, college standards to get the best possible allergy and medical history information from a patient. So you're going to enter. You'll get a screen looking like this. You'll add new. We're going to put in amoxicillin for today. And if you happen to know the allergy type, if they can share with you what type of allergy, was it mild or severe? I'm going to put for my patient rash on legs. Sometimes that's what they're feeling is their allergy. I'm going to put OK. It will come up as this, and you just simply have to say if you're pleased with that, you're going to file it. If you needed to add more, you would press the word new, and again, add another. So I'm going to say file. The answer is yes. Automatically, the cursor says, are the allergies confirmed? I'm going to say yes. Then it's going to ask me again, do you want to return to the allergies? This is for those potentials who will often say, oh, by the way, I forgot I have an allergy to cherries or another drug or So this gives you a few options because of that screen being a little bit challenging to work within. We need the access here. So I'm going to say no. An allergy ban. So that is, yes, the emergent responsibility, the triage nurse. You as the most responsible nurse seeing that patient next for when they're brought into your zone, you would ensure that the bracelet is there and it does have correct allergies on it. Home medication. I'm going to put yes. And really our emerge triage nurses expected to put down the most pertinent. If there's a head injury, yes, we want to know, are they on any blood thinners? So this is an opportunity for us to get a basic level, a basic idea around their medication. If our triage nurse has time, they'll often do a more in-depth one. We don't need frequency or dosaging here sometimes at this point. But if you have time, they will. Today I'm putting in ASA and I'm going to put daily. I'm going to say yes for today is a T. And just to let you know, under medication as well, if the patient presents with a list, we can photocopy that and adhere it to the chart. And right here it states patient provided medication list, copy on chart. I could put yes there. Just moving back a little, up to date with tetanus. So this would be really anybody that's had a laceration or any type of wound that's gone through skin penetration or laceration. We need this data. If they've had a tetanus is good for 10 years. So if they have had an injury, they're unsure. They think it might have been 5 years ago. I'll be honest, we will typically give that. This is a chance for us to get that updated. If it's unknown, we can click unknown right here. So for today, I'm going to put unknown. Pediatric immunization, that will stop you there as well. And again, another very important yes or no. You've seen and heard perhaps in social media in a lot of areas, but there's still controversy over pediatric immunizations out there, and knowing we need this. We've had a 4-year-old come into our department with abdominal bloating, presenting with petechiae. No immunizations were done. Our triage nurse did the perfect thing. She isolated her immediately. This child ended up having hepatitis along with another blood dysplasia. And the fact that the immunizations weren't up to date, so they put her in a negative pressure room when that became available. And all of those were perfect steps. So just to let you know, that's a key question. And advised to return if condition worsens. So this is very significant for triage to tell, especially if they don't have a space in the department for that patient. The patient needs a point person. So they are told, please come back to me with any concerns or if your condition changes or worsens. And then advised NPO. So Our Lady will not be advised NPO. But when would you do that? Definitely advise NPO if they're in abdominal pain, if you're foreseeing any form of surgery down in their future, if you're foreseeing, an appendage or a deformity that may or may not require surgery. And often with even diagnostic imaging being part of their plan, we sometimes advise NPO if they're already feeling queasy and unwell. We don't want to induce any form of vomiting, but an average for my patient today, I'm not going to tell her any of that. She's fine to have SIPs or whatever she would like. So past medical history, again, doesn't need to be too lengthy, but knowing that our goal is to get the best possible medical history. So we'll ask, vaguely, do you have any heart or lung problems? Are you diabetic? Have you had any cancers? Surgeries? For surgeries, you definitely put in the date if they can give that to you. Put that down. Breast removal. And cancer, we can put yes, and 2010. It will bring us down to smoker, HIV, hepatitis C, very important. We're often drawing blood work. We're the only area that typically asks this right away. Alcohol intake, it's a yes or no here, so potentially a yes. The date of the last drink. These are significant questions, both date of last drink and time. We've had a gentleman who came in who wasn't asked this well and required surgery, was basically post-operatively went into the DTs and was intubated and taken to our intensive care unit. So part of that challenge was that he was a very high functioning alcoholic, and knowing they can go into DTs as early as 6 to 8 hours post their last drink. We know they don't often, patients don't often answer this question accurately, but it's very significant. Recreational drugs is here as well. Have you ever been emotionally, physically, or sexually abused is a question that is mandatory to ask for all patients, female patients, 12 years and older. This is a new mandated, not new, this has been mandated for approximately the last 10 to 12 years. And our goal is definitely when patients come in and they have this chief complaint, we deal with it quite well. We get our DV SARP team, Domestic Violence Sexual Response Program team, offered to them quite quickly. But we're still to ask this regardless of their chief complaint and why they're with us. And the purpose is to catch those women. Hopefully it'll advance to men, I think it should. But right now it's women directed, 12 and older. And our goal is for that potential person who's living with a horrible situation, 3 months down the road, will recall that the triage nurse did ask them, and we are a supporter or resource for them to come back to. Again, here at the bottom of this page, you'll assign the triage level. And for our patient today, I think I'll give her a 4. And implied consent denied, just because we're in test, this is coming up again. And then the zone color. So we have 3 colors at Belleville site: green, yellow, red. Green being least acute, so we're fast track, see and treat. Yellow being our shall I say more stable 2, level 2s and 3s. And then of course red zone is our acute, so levels 1s and 2. For today, Our Lady's ambulatory. I know she is 91 with a cane, which I'll show you in a moment, but I'll put green. So seeing these other assessments that are highlighted green, these are recommended assessments. I definitely will, for my patient right now, do a falls risk. I'll show you what that looks like. We like this to be done out in triage if possible. So if it's not done, we ask that when you're the most responsible nurse, if you could try and do that. Every patient over the age of 16 is to have a falls risk assessment tool done. And a patient under 5 and under, is deemed automatically a falls risk. So a child 5 years and under will already be considered a falls risk. So has this patient had a history of falling in the last 3 months? Our Lady is a no. Confusion, I'm going to say no. Intoxicated or sedated, no. Impaired gait, I'm going to say yes. Does she use a device? Yes. And altered elimination, we'll say yes. That makes her a 3. 3 to 4 is a moderate risk for falls. I'll press OK. The other items that are here are recommended, and triage will not be doing those, but this would be recommended for within the department. So for now, I'm going to exit out. I call what I'm exiting out of, this is like, to me, the face of the patient's chart. I'm coming back, and now I'm at the triage nurse screener again. I've got test happy, female, 91, cough, chest, congestion, triaged, and 20, oh, just flipped to 27 minutes there. Okay, so that should end this particular segment, and hopefully you'll be okay with that. Thank you.